Knowledge Cluster, I welcome you all to this next session of the Epidemiology course. And we all know that we have with us today Dr. Vidya Mave. You have already met her during the last session on Tuesday. And we'll be soon starting with her session. But just before that, just one instruction about change in timings of a session on 24th. So on 24th, Dr. Anant Bhan would be taking a session, and the timings for that session is changed. Instead of 11, it would be at 3 o'clock in the afternoon. So we would request you to kindly block the timings for that. We will be sending you an email about the time change. The link remains the same, but we will soon send an email. So please make a note of that. So coming back to today's session, we have Dr. Vidya Mave with us for her second session in the series. And over to you, Dr. Vidya.
Thank you, Dr. Prachi, and welcome back, everyone. And on this session, it is a little more complex topic. And so I try to give lots of examples so that it is easily understandable. So you may recall last week we talked about our last session, we talked about case reports, case series, and descriptive epidemiology. And here in this figure, just to recall, so the highest level of evidence happens with the clinical trials, and the lowest one happens with the case reports. And this one actually clearly shows what are the significance of the study designs are. So you may recall most of our clinical trials or cohort studies or case reports or descriptive epidemiology, case series, etc., happens for us to develop evidence that can help with the policy making at the national level, at the local level, at the international level, at the World Health Organization level. So I just put this slide again from last week just to show that what are the strength of evidence are happening with these kind of trials. And as you can see, descriptive trials, descriptive studies, which we discussed last session, develops hypothesis, and then randomized control trial here actually tests links experimentally, the exposure and the outcome. What are the links between the exposure and outcomes that we look at using randomized control trial, and it is of the highest evidence. It's actually considered a gold standard of research designs because it provides the most convincing evidence of relationship between exposure and effect. So we talked about last week, or last session, that when an exposure happens, an effect happens between two different groups. So this is a link between two exposure and the outcome needs to be in place for us to make any decisions on whether that exposure helps with the outcomes. For example, talking about a medication, let us say we have a malaria drug, which is to be given to a population, but we need to understand whether that malaria drug is effective in decreasing mortality or deaths or hospitalization associated with malaria. So that is what the exposure and effects are. So what we try to do then is to identify there is any relationship or there is a better outcome that happens with the drug, in this case, malaria drugs, or a device. For example, if somebody has a heart problem and gets these tachycardia or ventricular fibrillation, we call it, which is an arrhythmia, it is an abnormal heart beating. If that happens, then we can put a device inside the heart. And that can help prevent these kind of whenever abnormal bleeding happens, it actually helps to reduce that events. Or it could be a behavioral intervention, like, for example, people who are supposed to be taking medication for a long time, but are not taking because they do not understand what that medication is doing to them for their health or their family's health and so on and so forth. So then you give an intervention like a motivational interviewing, or there are several kinds of behavioral intervention that can happen to have a better outcome. So what we do in a randomized control trial, it is a design where study subjects, meaning participants, potential participants, are randomized assigned to treatment versus comparison group. And it's the most convincing evidence between the exposure effects happens. Only caveat though in the randomized control trial is if it is found to be unethical. It could be sometimes when you say certain drugs can be given, but it's actually already given as a normal standard of care. And then you cannot experiment that drug because then you must give that drug to that patient who has that disease. Then it is otherwise, this is not going to be possible. I'm giving you an example of one of the clinical trials which I was involved in. This is where what we did is we had these people who have HIV positive. Their CD4 counts were less than 100. And then, because we know that HIV positive is at risk for developing tuberculosis, we are trying to see whether we should treat them for tuberculosis in the beginning when they get diagnosed with HIV. Or we could just give them just preventive therapy, which is isoniazid preventive therapy. That is what we did. And we followed these people over 18 months. And then we found out what were their risk of developing tuberculosis when they got randomized to these two different options. So that is what the randomization is. So this is schematically showing the exact same thing which I described. A study population in the case which I showed you is HIV positive people with the low immunity level. They are either going to go for interventions. Up here is the intervention. Intervention is a TB treatment, or control. There is just giving a preventive therapy. Then we follow them over time for an outcome. Outcome is development of tuberculosis. Here also for control groups as well as the intervention group. Some of them will have an outcome, some of them will not have an outcome in both the groups. So, and then this outcome then is measured whether it is lesser in the intervention group or on the control group. So how do we really do randomization? So it is, when you have, a person who is standing in front of you, you have to randomize him either to a treatment or to a control, continue what is supposed to be happening as a standard of care. So you could flip a coin and say heads happens and he gets this, he gets to the experimental arm. If it is tails, then it goes to control arm. We don't do anything to them or continue the current care. There are many ways to do that. Here I've given some example. There are a roll of a 6 sided ones and then dice, and then you see even number versus odd number, or it could be done in a computer generated manner using a certain kind of software. So I wanted to start understanding how a clinical trial or a randomized control trial happens by giving you an example. This is a very old Salk polio vaccine trial. It happened in 1954. At that time, what they did is they wanted to find out, how do you prevent polio among children? Polio usually affects children, as many of you know. So they went to a population. Who are the population? School children, who 500,000 school children, 5 lakh school children. Approximately half got the vaccination for polio, and the other half got a placebo, means they got no polio vaccination. So the defined population here is school children. They are randomized to either polio vaccine or no vaccine, because at that time in 1954, there were no vaccines available for polio. So they got nothing. They got no vaccine, current treatment. And then they were followed over time. When they were followed, they looked for polio among these people, among these almost 500,000 people or over 4 lakh people. They looked at whether they got polio or not. So in the vaccine group, 82 of them got polio. In the placebo group, there was 162 people got polio. So what we were trying to see in a randomized control trial, you develop hypothesis. The hypothesis is that it's called null hypothesis. Is there an association between the vaccine and development of polio between these two groups? So the one hypothesis is null hypothesis, where we are saying anybody who gets a vaccine or a placebo, there is no difference means there is no difference, there's no difference between vaccine versus placebo of those children who are going to be developing, whether they develop polio or not. An alternative hypothesis says vaccine is better in preventing polio compared to placebo. So how do you actually do these kind of differentiation? You could do it in a different manner. Estimates of association can be just a difference in proportion of those getting vaccine versus placebo of their risk of developing polio, or there could be relative risk, which we can talk about in the next slide. So this is kind of really a complex idea, but it is quite simple enough if you say that. So what we are trying to, our hypothesis, we are giving vaccine in this group and placebo in this group, meaning that if this group and this group development of polio would be same, that's a null hypothesis. But we are saying vaccine group does better than the no vaccine group, then it is alternative hypothesis, where we are proving that that hypothesis, we want to prove whether vaccine does better than placebo. And how do we see whether it does better or not? Is there, we could just look at proportions, or there is something called relative risk. That is an estimation of outcome, what is a better outcome or not. So relative risk, I don't know whether you have already heard about it, but I'm anyway going to talk about it a little bit. It is a little complex. You can look it up in Wikipedia perhaps. Is that how do we measure this relative risk? Is incidence of outcome among exposed. Here in this case, in this study, SAC study, is a polio. What is the incidence of polio among those who got the vaccine, polio vaccine? And divided by incidence of outcome, polio, among people who did not get vaccine, non-exposed. So that's what we are trying to do here. This is how relative risk is measured. Here, so we know 82 out of 200, 2,745 people. This is the incidence of outcome among them. And among placebo, 162 developed polio of total 2,01,229. So that's what I did here. I showed it here. So relative risk is 82 divided by 200,000, 162 divided by 200,000, and it actually comes out to be 0.51. So the way we interpret is that 0.51, the risk of polio is reduced by almost 49%. 1 minus 0.51 is how we interpret this. That is 0.49 is the difference. You know, it is usually mentioned as a percentage. So 49% less people actually got polio if they or of the school children if they had received vaccine. That is the interpretation here, saying that SAC polio vaccine was 50% effective, in almost 50%, I mean 49% effective in prevention of polio. So this is how this study was conducted. So similarly, one of the studies which were done by our group is to looking at HIV exposed infants. So mothers have HIV and they were just born. And at the time they were randomized to either they get 6 weeks of anti-HIV drugs, that's called nevirapine, or they just get 1 dose of nevirapine at birth. That was at the time was the standard of care in 2001 or 2000, in year 2000. And then they followed these babies to see how many of them got HIV themselves, that is HIV transmission, at 6 weeks or at 6 months. How many of those children died or the infants died? That is at 6 weeks and 6 months, and whether they had HIV transmission and or death that is happening among these infants who are HIV exposed. That means their mothers have HIV. We don't know whether they have HIV or not. We are trying to follow them up to see whether they have developed HIV or they died because their immune system is bad, and so on and so forth. And we found in this trial that at 6 weeks, at 14 weeks, and 6 months, and all these time points, the deaths among these children who received 6 weeks of nevirapine, this is the experimental regimen, 6 weeks of daily anti-HIV drug, they actually did better. they died, the deaths among them were lower compared to those who got only one dose of nevirapine. Now, because we are in COVID pandemic, I just wanted to give an example of a COVID studies that have been happening around the world. So you may have heard about an antiviral called remdesivir. So in this study, what they did is they looked at over almost 600 people who have moderate COVID-19. Moderate COVID-19 meaning that they actually require some oxygenation. They have symptoms of COVID. They were diagnosed with COVID, but they require some oxygen, and they also may require steroids, which is now a standard of care. So of these people, 596 people, they randomized these people into 3 different arms. One arm in 200 people, they just continue to get the same care as they are getting at the time. This is about a year back, where they all got oxygenation, they got support in terms of their fever, they got an antipyretic medicine, anti-fever medication, and if they have cough, they got cough medicine. They also got whatever required, like corticosteroid, that's a steroid dose they got, which is a normal standard of care at the time. But the rest of the 400 people got randomized to another 2 arms. One arm got 10 days of remdesivir, the other arm got 5 days of remdesivir. So that is what they did. Then they followed them over when they were in the hospital and looked at what will happen in their clinical status over time. Whether they got better, they got hospitalized for a longer time, whether they died based on these 2 medications, these 2 doses of medication. So it is not only about medication or a vaccine, it could be doses also, whether 10 days works better, 5 days works better, or neither works better compared to standard of care is what they looked at. And they found that 5 days remdesivir actually was beneficial by almost 65% of the people. This is how this has been interpreted. It's pretty complex way to understanding how to interpret these results. Is they did the odds ratio, your proportional odds ratio, because that is one of the ways you can evaluate an outcome, whether it is better or worse, because we are looking at the time to event. So these are all complex ideas. So for this, you need advanced epidemiology training. And here, 1.65 times is a better outcome among 5 days remdesivir as compared to standard of care that was no remdesivir, while 10 days remdesivir actually had no effect. There was no difference between 10 days remdesivir versus a standard of care. So this is a couple of ways where we could do these kind of randomized clinical trial. But what is the issue with the randomized control trials are that they're very expensive. Although they are gold standard, everybody wants randomized control trial to make guidelines, international WHO guidelines and so on, World Health Organization guidelines. But they're very expensive because it requires development of protocol, a careful randomization has to happen. So you require biostatisticians, you require data managers and stuff like that. When they get randomized, somebody has to talk to them, counselors, clinicians are required. Then there's going to be lots of lab tests because you're giving an experimentation to somebody. You want to make sure it is not affecting them in any way in terms of their blood test being abnormal or they're having any side effects because of this new medication. So there's going to be follow that happens quite a bit once you get randomized to the trials. And then so it requires lots of careful evaluation for a long period of time. That's why it becomes very expensive. And sometimes it is not a right design. If there is, you cannot really do a standard of care or a randomized control for steroids, because initially when COVID-19 pandemic came, people started using steroids. And now if you want to try and see if tomorrow I want to do a trial of steroids among severe COVID-19 patients, whether it works or not, I really cannot do it because there's actually standard of care. It becomes unethical because then that is not a good option to do these kind of trials. I just wanted to touch upon a community trials. It's also, again, a very complex study, which we had done. Excuse me. 4 districts in Maharashtra. Can you hear me? Am I audible?
Yes.
Yes, okay. 4 districts in Maharashtra, and then we randomized, HIV caregivers. They are not really caregivers, they're outreach workers, to 2 arms. In one arm, they are actually, what they do is these outreach workers, ORWs we call them here, outreach workers are usually in constant touch with HIV positive pregnant women who are about to give birth to their children. So what they're supposed to do is they're supposed to take care of their HIV medication in a regular way and then follow up with the doctors and make sure that their virus in their body is quite low and their immunity is quite good, so that the children, the babies which are born to them, do not get HIV. That was the idea with the program. There's a program in India, which Government of India called National AIDS Control Organization, which handles this care. And they're given this responsibility to these ORWs, outreach workers, to do this kind of, making sure that women actually take their medication in a regular manner and so on and so forth. But the problem with that is that these women who are going out in the community and talking to these HIV positive women do not have any tools to help them, making sure that they counsel properly and stuff like that. So what we did is you asked them to use a mobile health platform where we give them videos to show it to women, why it is important for them to take medication, why it is important once the baby is born that they breastfeed. Although the risk of HIV may be a little higher with breastfeeding, it also prevents death of the children because breast milk contains immunity, good immunity for the children. So these babies don't get, infections like diarrhea or cold coughs and stuff like that, which could be dangerous when they're very small, tiny babies. So we did those videos and we also gave them some counseling tips. The women are saying, I don't want to take medicine because, my husband, doesn't like me taking medicine, or my mother-in-law is scolding me or something like that. So these are real issues that happens on the ground when they are not highly educated and so on and so forth. So that is the intervention we did. We randomized almost over 1,000 women who got into these 2 arms. One arm got these additional tools where they had videos, counseling that is happening through mobile. The other arm just simply did the standard of care, what they're supposed to do, what outreach workers are supposed to go and talk to them in person and take notes in diary and stuff like that. What we found when we gave them these either videos and counseling, additional counseling, that actually helped this woman understand what their diseases are. And that actually improved when they were followed for 1.5 years after we did this kind of intervention where we continuously talk to them on a regular basis, every month basically, that they improved. The breastfeeding among those people actually quite high. And they also, all the children, all the babies who were born to these HIV positive women also made sure that their infants got HIV testing done on a regular basis. So that is very important. If you test early, you can treat faster. If you treat faster, the likelihood that they have a normal immunity, like a child did not have HIV positive, is very much higher. That prevents them from getting further infections or further problems in their entire life. So as many of you may know by now, that HIV is no longer a disease which actually make people die faster. It's because it's become a chronic condition like diabetes and hypertension. With proper, ensuring proper use of medication, they can live forever, just like a regular person who does not have HIV. But sometimes randomization is not always possible, right? Although we would love randomized trial to happen, it's not, as I said earlier, there is already a standard of care, but we don't know whether it works or not, but we cannot really do randomization. So then it has to be a natural experiment where it's naturally happening and we are trying to see whether it's any difference in outcomes between exposure and outcomes. So it is not as good as randomized control trial, but it was very close to randomized control trial in terms of strengths of evidence, but we don't really have to do any randomization. We don't have to flip a coin or use a computer system to see this person goes to treatment, this person goes to standard of care. Instead, the design, we call this as in cohort studies. This is an observation design. So I'll give you very few examples of how these studies are conducted. Here in this design, we compare individuals with the known risk factors and exposure with others without the risk factors or exposure. So we are actually looking at the difference in the risk, whether there's an incidence is happening over time. This is a kind of an observational design. As we already spoke about cross-sectional study last session. That is also an observational design, but it is lesser in terms of strength of evidence. This cohort studies are a highest strength, best observational design, and data are usually collected prospectively and sometimes retrospectively. So this is a prospective study design where there is a study population which is free of disease, maybe. Then they have some kind of exposure happening or factor not happening. And some of those who have exposure happening, they develop disease or no disease. And some of them, again, same way, they do not have any exposure, but they may have also developed the disease. And these people, this study population are followed over time so that we can look at what outcome disease developed or not. That is the outcome we are looking at. So looking forward, it's a prospective cohort. We already discussed that on the last session, where we follow over time. And here in the prospective cohort study, we measure the exposure of confounder variables, meaning that I'll give you an example right next here. A person who is here today, for example, a person who has a TB, right? Let us say he has TB. Now, he also has diabetes that is exposed, right? And some of them do not have diabetes, no exposure, no diabetes, no problem with diabetes with that person. Then we look at whether they all got cured or not cured. So outcome is cure, whether there's a better cure here or better cure here, no diabetes person. So what would you think? Diabetes is also a bad disease, right? It actually makes your immunity go down. It's possible the person who has tuberculosis, who has diabetes, would have worse outcomes compared to diabetes person, tuberculosis person who do not have diabetes will have better outcome. So that is how a prospective cohort studies are done, where we actually look at a certain number of study population and follow them up over a set period of time, 18 months, 24 months, and so. And we look at what is the outcome differences in proportions, either proportion, it can also use relative risk or also use odds ratio. This is another study which I was involved in, where we looked at what are the risk factors for early mortality among advanced HIV patients. So looking at who are already taking antiretroviral therapy, is there some factor which makes them at higher risk? So this group have been enrolled of almost over 1,000 people were enrolled in this study, and they were prospectively seen whether they developed any outcomes or not. So this is the one which I was telling you earlier. So we actually had almost 1,700 people who were diagnosed with TB. Of that, 245 of them had diabetes as well, while 587 had just TB. We followed all of these folks for about 18 months after they got diagnosed with TB. So our question was, does diabetes cause any worse outcomes for patients who have TB? What we found out that there was basically no difference. If they had diabetes or no diabetes, the risk of developing bad outcome, not cure, is actually similar between those who have diabetes and no diabetes, cure. But what we found that the people who had diabetes, this is a red line here, who have diabetes are more likely to die when they get TB as compared to people who have no diabetes, especially in the first 6 months when they are on treatment. So this is an important finding where we found that diabetes is very important. Management of diabetes when they have tuberculosis is very, very important and has to be done in a timely manner. Cohort studies can also look back. It is looking backwards. So now, there we can do the exact same thing. We are still looking at the exposure in the case of our study, diabetes among tuberculosis people, whether that has an outcome. But now the data with the patient population is already there. There is Sassoon Medical College and BJ Medical College in Pune. In the Sassoon Hospital, there was, maybe I'm just giving an example. It's a hypothetical situation where there is 2,000 people who have tuberculosis. Of the 2,000 people who have tuberculosis, about maybe 500 of them also had diabetes. This is already, they've already been taken care of. They've already have finished their treatment. They're already there in the system. Somebody goes back and looks at their charts and finds out whether diabetes actually caused any worse outcomes. So this is one of the studies which I did. Again, this same study which I talked to you earlier about mother-to-child transmission of HIV, whether there was, in the same patient, there was a cohort data available. There was almost 747 mothers and their children who were, on follow-ups. So they were followed for almost a year and a half or so. So of that people, we did retrospective assessment. As a cohort analysis, we did 689 HIV positive women with or without hepatitis B from this trial. And we looked at whether the mother actually had not only HIV, but also hepatitis B, which is a liver kind of viral infection. Did that increase the risk of transmission of HIV to their child, is what we asked. We did not find any association, but that's okay. We need to know this information, whether it's positive or negative, we need to know this information. That's what we did here. So as I said to you, that cohort studies are, prospective and retrospective, similar to descriptive epidemiology, but this is the strength of evidence quite high, because we can actually find out, which I described earlier, tuberculosis or hepatitis B transmission of HIV and or less cure in this case. And it can, I just gave you one example where we had only one exposure. It could be multiple exposure or multiple outcomes. That also you can look at in the observational trials. But the limitation again is, although it is less expensive than randomized control, it could still be expensive, because if you're doing prospective cohort, you might, because you already know what you want to identify, right? So you'll be testing them quite often, following them for a long time. So then you need a clinician, you need a laboratory people to do this one. That could become quite expensive. And there's a risk that some of these people, because they are not getting any treatment, they may not come back for a follow-up. So sometimes we miss several of these people. That's called loss to follow-up can happen, and so on and so forth. So the next kind of observational trials which we do is a case control study. So I'm just going to touch upon case control study a bit. It's an important study design where the data is already there. Exposure data is already collected and it's already present. So you actually look at, in most of the case control studies are looking backwards. So retrospectively, you're going to do that. It's very good kind of design when outcomes are quite rare. I mean, I'll give you an example, for example, at a later time. So here it's almost a similar thing as that of a prospective study, but it's different in the sense that we are looking retrospectively. The cases who have diseases and controls who are no diseases are already present. Then what we are going to do is to see what kind of, certain exposure was the reason why cases happen, more cases happen in that group, in this population, as opposed to people who did not have disease. So that is what we are looking at in a case control trial. So again here, this is where we start. When the study populations are there, we already know how many of them are cases happen, control happen. So we are looking backward. Then we are saying what factor present caused these cases compared to the factors present in a control group. So we are trying to actually look at the exposure and outcome. Outcome is here disease, right? Disease is always an outcome. So exposure is factor. This factor present, factor absent, factor present, factor absent. The control who did not have disease. What is the proportion between these people? Again, same idea. Idea is same. Exposure happens, disease happens. Whether people who have disease, who do not have disease, what kind of exposure happened to them? Similar or different? That's what we do for case control studies. I'm giving you an example here. Here, the research question is, people who drink alcohol quite a bit, not in a like a leisurely manner, but they are dependent on alcohol. Quite a bit of consumption of alcohol happens. Whether their risk of esophageal cancer, food pipe cancer increases or not. But you have to remember, esophageal cancer, that's a food pipe cancer, is quite rare. It does not happens, So if you're going to do a cohort study, you have to follow them for a long time to develop. It can happen in 5 years, it can happen 10 years, 15 years, 20 years. So it's a very rare condition. It's very difficult to do a prospective control study. So what people then do is they take around 200 cases who already got diagnosed with, esophageal cancer. And here 755 controls were taken. And who actually are, controls are usually matched, So let us say we have 200 cases of esophageal cancer. All of them are anywhere between 55 and 75 years of age. You take them. Then you also find people who do not have esophageal cancer who are also belonging to the same age group, 55 and 75. And then let us say 200 people who had esophageal cancer, 100 women, 100 men, and exact same thing you do in the controls also. You take almost 50% proportion of men and women controls as well. So that is called age and sex matching. You generally do that for a case control study. Then we look at alcohol consumption, each one of them. 200 cases, how many of them were drinking alcohol, how much alcohol, and 775 controls. Again, their age and sex match to the source of, cases of esophageal cancer people, and how much they are, how long and how much alcohol consumption they do. And we actually, in this case, they looked at if they are taking more than 80 grams per day of alcohol or less than 80 grams. So don't ask me how they did it because I'm not an expert on measuring alcohol, but I'm just giving an example here. So total of 975 people, some of them got 96 of the cases actually had, of 200 cases were consuming more than 80 grams of alcohol a day. 109 of control people of 775 were also consuming more than 80 grams per day. That is considered quite a bit of alcohol consumption. So now we have to see whether alcohol was increasing the risk of esophageal cancer, right, in this case control study. So we actually measure, what actually we are measuring is the odds of getting esophageal cancer. Odds of getting esophageal cancer if you drank more than 80 grams of alcohol a day. So this, we measure it as an odds ratio. It's called an odds ratio. Odds ratio is in terms of evidence, is lesser than relative risk, but it is still a good measure because this is a rare condition, esophageal cancer, rare condition. There's no way we could get a relative risk. So we are going to do odds ratio here. This is how they are done. So same 4x4 table we have done here. This 4x4 table, we actually look at 96 into 666 divided by 109 into 104. And what is that? 5.6. This number actually is 5.6. What does this 5.6 mean? It means that individuals with higher, more than 80 grams per day of alcohol consumption have over 5.6 times higher risk of developing esophageal cancer. That is what it means. Odds ratio of 5.6 means they have 5 times higher risk of developing esophageal cancer if they were consuming more than 80 grams per day of alcohol. I did a study called vitamin D deficiency. My question was whether vitamin D deficiency increases the risk of postpartum tuberculosis among HIV positive women. So postpartum TB is very uncommon. Postpartum means you gave birth to a child, and then after that, when you give birth to the child for another 18 months or so, what is your risk of developing TB if you had HIV? So that was the question. So you know that women in India, or all of us basically, not only women, everyone who do not get enough sun exposure can have vitamin D deficiency. And this risk, vitamin deficiency risk, may be higher among pregnant women because they don't go out, they may be sitting at home, or they are not probably getting enough supplementation through their foods and stuff like that. So the question here was there a risk of developing postpartum tuberculosis if they had a vitamin D deficiency. That was the question. So we looked at here, OR means odds ratio. This is what we did. We looked at the odds ratio among these women. I'm trying to get rid of this screen thing, and this is how we found out that an adjusted odds ratio, it looked like, at least in the study, women who, an HIV positive woman who had vitamin D deficiency had like 57% higher risk of developing postpartum TB after giving birth to the child, as compared to the ones who did not have tuberculosis after they gave birth to a child. That is what we want. Her cases are who? Cases here are HIV positive women who already had postpartum TB, had the TB after they gave birth to a child. Our controls are similar age group, because they're all women. We don't have to match for sex now. Age groups are similar, but then they did not have postpartum TB. Generally, it's a 1:2 ratio we took here. So it could be done in 1:3 ratio, 1:4 ratio. Cases could be 1, controls could be 2, 3, 4 times higher number. Controls could be. But in this design, I mean, as your numbers actually increase, sometimes strength of association may go higher. That the odds of getting outcome or relationship between the exposure outcome may be higher, but it just reduces after 1:3 ratio. But in this case, we use 1:2. One case and 2 controls. That's 1:2. One case, 3 controls is 1:3. One case, 4 cases. So more than 4 people generally don't do it. 1:1 also can happen. 1 case, 1 control. There is 200 cases, 200 controls, or 200 cases, 400 controls, 1:2. 200 cases, 600 cases, that is 1:3. Those kind of association can happen. So it's a good design. It's less expensive and time consuming. And it's very efficient to studying very rare disease. Like postpartum TB is quite rare. It doesn't happen to a lot of women, or a lot of people anyway. And similarly, esophageal cancer is very, very uncommon. Same way, lung cancers, leukemias and stuff like that. Uncommon case control studies are the ones which are used. But it is really not very appropriate for studies where we really don't know what kind of exposure is already happening. So at that time, maybe it's less efficient in that cases. And then because we already know outcomes have happened and we are maybe having some kind of biases in our mind that can influence the selection of subjects also. And also we really don't know. So in the esophageal cancer study, people are going to think how much alcohol I drank, when for the last so many years, people may say I drank more than 80 grams or less than 80 grams. There is no way to compare or confirm how much alcohol they did because it had happened in the past. They have to recall it. So there will be a recall bias that might be happening in those cases. So I have a couple of quiz here. And I see there is a lot of chat comments are there. Maybe you can do the questions here or responses here for these questions. So this is identifying the type of the study. Are you ready? So the first question is a study in July 2021 assessed how many of the COVID-19 patients died from COVID-19 until December 2020. So what do you think is the type of study it is? It's a retrospective cohort study. That's correct. Correct. A couple of them said retrospective cohort study. Next one. This study actually took 200 people with anemia, 200 who have no anemia, and they looked at what is the iron level. See the association between iron level and anemia. What kind of study it is? Yes, case control, correct. So it's a 1:2 ratio and case control study. Very simple. Right now it's becoming very simpler for people. I'm very happy. This is a study where we looked at the effect of an anti-cholesterol drug, high cholesterol drug called simvastatin. And we randomized people to simvastatin versus placebo and looked at mortality for people who already have heart disease. And then we are actually looking at the effect of simvastatin versus placebo. And it is a randomized controlled trial. That's correct. Very nice. Very nice. So I guess I successfully kind of went through the most important parts of epidemiological design. There are many more designs, which I have not mentioned here. There is some designs called cohort studies. There are designs called BAB equivalence, bioequivalence and bioanalytic studies, where sometimes we look at the plasma drug level, blood drug levels of certain drugs. There are study designs which are done to look at laboratory aspects of an agent. For example, they are called basic science research. So generally, basic science research, where initially people develop a new drug and then they take it to preclinical data, we call it. They actually, before we do the epidemiological study design, they are being used in mice, mouse mice or rabbits or monkeys sometimes, and ensure that what kind of drug adverse events happen. So when we talk about randomized clinical trial or any where we are experimenting with whether this drug does work good or not, we are also not only looking at efficacy, but we are also looking at side effects. We have to make that kind of assessment. It is efficacious, but it has lots of side effects which are life-threatening. Then obviously that medicine is not going forward. So, but before we put it in humans, this kind of trial happening in humans, there's already evidence. Otherwise, the regulatory bodies, the Indian government bodies like Drug Controller General of India and so on, will not let you do these kind of studies because it's not ethical to do that if we already know that this medication doesn't work in animal studies or in other kinds of basic research science studies. And so those studies, it's probably for another time or another workshop in the future. But what I did here for the last two sessions are that in the last two sessions is that, or in this session, the previous session is that giving you a briefly an idea of most important clinical trials as well as epidemiological study designs and how they work. And hopefully I can take a few questions. I'm sure I don't know what time it is. Yeah, we still have 10 minutes. So good idea about how these study designs work in a very superficial level, obviously, because it's only 2 hours. It's actually, these courses are taken over 2 years, in time. So we try to put it down in such a, simpler manner.
Yes.
Yeah.
Thank you so much, Dr. Vidya. You have explained most difficult design in very easy and simple manner. And probably that is the reason you have several questions, because people have understood and now they want to explore.
That's great, yeah.
So there are many questions in chat box also, and I have got some personal chat also. I have received a few questions. May I request you to show your slides once again, because there are several questions based on what was shown on the slides. So especially the RCT related.
Okay.
Where we talked about odds ratio. I think one of the...
No, RCT, we talked about relative ratio.
Yes, relative risk and yes, odds ratio also. Because some questions are related to like, how do you get ranges in odds ratio? And can we use 2 outcomes in one study? So I thought, if we can use these examples and show once again. And there are some questions related to relative risk also.
Right.
And the chain of questions. Somebody is asking whether pre-post study design, it's called as RCT.
No, it is not called RCT. Pre-post is not RCT. It's called a time intervention, interrupted time series interventions. It's an interventional kind of design, but it is not it's not a randomized control trial. So in randomized control trial, you're actually Defined populations are randomized to either an experimental treatment, or continue the standard of care, whatever is available at that point. Sometimes nothing is available. At that time, you give placebo. If something is available, let us say there is a standard of care right now happening, that you continue. That's another non-experimental, unexposed group. That is two randomization must happen. So relative risk is looking at the outcome. What outcome you're looking at? So in this case, in the polio trial, we are looking at outcome as development of polio among school children. So does it happen more or less in the vaccination group versus no vaccination group? That's what we are looking at. So this is where relative risk is happening. Now, I did show proportional odds ratio. Proportional odds ratio is not a simple odds ratio. It is actually kind of looking at the difference between outcomes at certain time points. So here, in this one, relative risk is you're actually following people for a long time and looking at different outcomes. So this is one kind of a design. There is different way of estimation of the outcomes, whether there's a relationship between the exposure and outcomes. So in this trial, they chose proportional odds ratio because it's where they looked at what is the proportion of the people with the 5 days remdesivir develop these kind of difference in clinical outcomes. So they basically looked at the different proportional odds ratio. Relative risk are most commonly used, but sometimes some of these clinical trials, which another clinical trial, remember, of tuberculosis, where they just simply use proportion. Proportion of people who developed TB after getting TB preventive therapy versus no proportion of them who did not develop TB between two groups. It could be proportion, it could be relative risk, it could be odds ratio. There's no way to say that it has to be one way or the other, depending on the way you designed earlier the study with the biostatistician and the clinical group who feel more comfortable with what kinds of outcomes. So in this trial, in polio trial, what they did is they just simply looked at polio, one outcome. While here in this trial which our group was involved, this was not one outcome. There were 3 outcomes we were looking at, 3 different kinds of outcome, primary outcomes. One is HIV transmission to babies, second one is death, or it is HIV transmission or death. So it could be multiple outcomes. So there is a way to do statistically, to do multiple outcomes can be assessed in a single clinical trial. Here also this remdesivir, again, this one is also not a single outcome, it's a multiple outcome. They looked at, followed the people for clinical status distribution, how many of them required ICU admissions, how many of them, how long they stayed in ICU, how many died. So multiple outcomes were looked at here. So it is not necessary that you have to have a single outcome. That is the case even with observational cohorts as well as case control designs, because several times outcomes could be a combination of multiple studies. For example, I showed you one of the studies which I was involved in, this one, diabetes and tuberculosis treatment outcomes. So what could be a possible tuberculosis treatment outcomes could be? It could be multiple. People could be cured of tuberculosis. Some of them may develop a new event of tuberculosis after they stop treatment called tuberculosis recurrence, and some of them may die. Each one of these events are quite rare. About 100 people who get treated, about 15 of them will develop one of these outcomes. They might develop, TB after they stop treatment, they may die, or something called treatment failure, they never get cured. So those 3 outcomes can happen. So what we then do is these outcomes become then combined. It's called composite outcomes, composite unfavorable or adverse outcomes. We combine this, whether these people had either died or they had repeat event or they did not get cured. So these 3 outcomes are put together, made a composite outcome. So in this study, actually, we did look at this multivariate analysis where I said there is no difference. Tuberculosis did not increase risk of bad outcome. Here we combined three such outcomes. That is how we got 1.13 here. And so it's possible to have multiple outcomes in all kinds of study designs. But exposures are generally 1 or 2 you look at. You can look at multiple exposures as well. You can come out with multiple risk factors, which risk factor caused which outcome, and so on and so forth.
Okay, so that means there can be one major outcome and multiple other secondary outcomes.
Right.
Okay.
And to be frank, when you're putting up so much money to a clinical trial as well as observational cohorts, people don't want to study only one thing. They want to study multiple things. And your scientific evidence actually exponentially increases. So it's very important to look at multiple things. So a study which I am involved in generally has 15 objectives. One primary, 2 or 3 secondary, and many exploratory, because we have no idea there's a relationship or not. So you have lots of exploratory outcomes as well.
Yeah. Right. Okay. Next question is about cohort study. This is again with reference to what you presented, TB and diabetes. What is the definition of cohort compared to just study population?
Cohort by man based that, so this is a so what we did is we looked at tuberculosis. There's a cohort, right? This is a population, study population, who are followed longitudinally. Means a cohort today, let us say doctors in all medical colleges in Maharashtra or maybe India, all doctors. So those are medical doctor cohort. So these are so many people, but who are followed for a long time. It means probably the same thing, study population, but scientifically we use that word. Study population is this, doctors, but then they are followed certain number of doctors of those maybe 2.5 million or 250,000, 25 lakhs doctors in the country. Of that, maybe 1 lakh doctors are followed over 1 year. So that cohort, that group of doctors, smaller group of doctors are followed over time. It probably could be used in a same way as a study population, but in general we call them as cohort. They are followed for certain time, either prospectively or retrospectively.
Okay.
I don't know the literal meaning of that. Obviously, you can look it up, but it probably can be used interchangeably as long as you understand the concept.
Okay. Somebody's asking, how does the retrospective cohort study consume more time?
It doesn't. It actually consumes less time because you already have the data available, right? For example, I've been involved with PKC, Pune Knowledge Cluster data. So data is already collected, it's already available. Then all you have to do is to make sure they have put it in the correct format for it to be analyzable. Clean it and then analyze it. It's possible to be happening in a shorter time compared to prospective. Okay. Most often that's the case, yeah. Unless you're procrastinating, I'll do it tomorrow, day after tomorrow, then it'll take a lot of time. Otherwise, it can be done.
Absolutely. So the retrospective cohort studies are more faster than the prospective cohort studies.
Right, but the strength of evidence is lesser. Because you don't have control, right? It's already happened. Yes. And a lot of time people are recall bias. If you're asking some self-report questionnaires, recall bias. You may remember, may not remember. And so when you're doing prospective, you can actually decide what data you're going to collect to see the exposure and outcome association. It's going to be very difficult to do it in retrospective study. It's already happened. You have no control.
Right. The next question is about case control study, and why is the number of people taken in case group lesser than control group, or why control groups are more?
It is a kind of a statistical association you're trying to see, right? So the cases already has happened, so you actually don't have control, right? It's again retrospective design. It's a rare disease. Already this has happened. Event has happened. They already got the outcome. Now, once the outcome happened, you're looking at another exposure and outcome, kind of association here. So you really don't have control. You cannot increase the number of cases. It's already happened. Then you look at controls, where you want to increase, making sure that this association exists or not, the association between one kind of exposure and outcomes. So you look at controls who are available who are age and sex matched perhaps are available, or maybe there's something else matched as well. Sometimes when you want to look at cardiovascular outcome, somebody who actually has a thrombotic event. Thrombotic event means blood clotting happening. It's a very rare disease, blood clot happening. And then so you're saying, okay, cardiovascular disease and thrombotic events, but diabetes, high blood pressure also can risk it. So you're also matching for that, perhaps. And then then you actually have more control on the cohorts who have controls, who have no disease, because there are more people who will not have a rare disease, right? So you actually improve your power. So we did not cover today what is power is. Power is like, there is a statistical kind of analysis which we do, where you look at, when you look at the association, what kind of power, how confidently you could say this association exists. That is called power. So generally for more than 80% power is what is desired. It doesn't always happen depending on the number of samples. So this all comes in the sample size estimation and power calculation comes. So if you get 1 to 2, 1 to 1, also sometimes there's enough power. If there's exposure and effect is very high, we may still have a good over 80% power, higher confidence to say there is an association. 1 to 2, 1 to 3 actually improves those kind of powers. If there is, there's still some kind of doubt, so you improve your confidence in how, exposure and outcome happens. That's what we're really trying to do by using higher number of controls. Because if the disease is, let us say we have only 33 cases, and then we only take 33 controls, numbers are such a small number, right? 33. Then it is very difficult to say one exposure led to this disease and only 33 people, another 33 controls. Then you say you want to improve that power by saying 33 people who have disease already are present. Now we are going to take 99 people, 1:3, because now 99 people, whether they also developed, they also have these factors or not. So then you can be able to more confidently say there is a exposure effect and outcome association. So that is where higher number comes. Please watch time. I have to go to another meeting at 12.
Okay. Can we have just one quick question?
Yes, please. Go ahead.
Can a case control study be prospective?
It could be. Generally, it is retrospective. It's a rare event. But some people do design prospective case control studies where they really want to know an association and design ahead of time. I am only going to be doing control matching for exposure, not the outcomes. Case control is generally cohort studies. No, I'm sorry. Take it back. Case control study by designs are outcomes already happened. It's a retrospective. But case control design for exposure can happen. It actually happens in observation cohort. So outcome has not happened. Prospective cohort means outcomes never happened. So in that case, you can do the case control design for exposure, not outcomes. In here, when we talk about case control, we are talking about outcome. Outcome has already happened or not happened. So I will actually give you an example. I actually, not by intention, it's already happened here. This study which we did, this one. The exposure is to diabetes, right? Diabetes and exposure here. So we actually did match for diabetes. So we made sure that group who are TB diabetes exposure 245, there is no diabetes 587. So that was by intention 1:3 ratio. 1:2 ratio was supposed to happen here, but actually it became a little more than 2 here, 587 compared to 245. So this kind of exposure case control can happen in a prospective cohort. It is not a case control study. Case control kind of exposure, 1:2 kind of exposure can happen. It's almost always case control studies are retrospective. Case control exposure can happen for a prospective cohort studies.
Okay, thank you for this very clear-cut, very clearly stating what and when to use what kind of design. There are a couple of questions which are related to ethics. I request participants to just hold on to these questions. We are going to have a separate session on ethics where we'll address these questions. Since considering the time constraint, thank you so much, Vidya, for lovely sessions last Tuesday and this Friday also. And we look forward to more interaction sometime in future. Thank you once again.
Thank you very much for the opportunity. It was a blast for me as well, and I appreciate you considering me. Thank you, and all the best for everyone here.
Thank you. Thanks.
Bye-bye.
Bye.
Bye.